The next speaker is a great lecturer, great friend, and he's one of the great guru, maybe area of diabetic heart disease, diabetes, hypertension, metabolic syndrome. That's Dr. Professor Keith Ferdinand of Tulane University, New Orleans. That's the president and chairman of the board of the American Society, ABC, Association of Black Cardiologists. He's always nice having Tube Side. He's a member of the International Society of Preventive Cardiology. Thank you.
Thank you. Good morning. How many endocrinologists, diabetologists we have in the audience? Endocrinologists. Good. I'm not one and I don't play one on television. I'm a cardiologist. But increasingly, we now know that the newer anti-diabetic, anti-hyperglycemic medications will be used not just to control blood sugar, but to control cardiovascular disease. So I'm going to look at the agents as a cardiologist from the prospect of where we're going to be going forward to control outcomes in heart disease. You'll note under my title that I'm chair in preventive cardiology at Tulane. It's named after Gerald S. Berenson, who recently passed. And I think I should take a second for you to recognize who he was. He had the Bogalusa Heart Study, over 8,000 youth in a biracial community in Louisiana. Starting in 1972, he actually identified the onset of hypertension, obesity, metabolic syndrome, leading to cardiovascular disease in children. So we now recognize that for our children, teaching them how to live and eat in a healthy manner is necessary in order to avoid what we're talking about today, these conditions in adults. Here are my disclosures. I've done research in blood pressure and most recently in blood pressure related to some of the newer anti-hyperglycemic agents, but nothing I'm going to say today conflicts with any of the ongoing recent data. I'll talk very briefly about the DPP-4 inhibitors. I'm going to spend most of my time with the GLP-1 agonists and SGLT2 inhibitors. For those of you who are not familiar with these acronyms, I will tell you exactly what they mean and specifically look at unique cardiovascular outcomes and perhaps give some reflection on where we're going in the future. Persons with diabetes have an increase in heart disease risk, 2 to 4 times more high rate heart disease rates, increase in death, increase in strokes. Heart failure, much more common in persons with diabetes, and it affects life expectancy, both for men and women. In fact, building on what Nanette has taught us, the effects of diabetes on heart disease in women is more profound even than that in men in terms of outcomes and life expectancy. Here you see the marked decrease in the blue at the top, the rates of heart attack and stroke and diabetes, but if you compare it to the general population at the bottom in red, there's still a gap, a disparity gap, where persons with diabetes have higher rates of heart attacks and strokes. This is a meta-analysis of over 500,000 persons. The line down the middle is the line of incidence, meaning that there's no difference between persons with diabetes and persons without. We can note almost all of the boxes are to the side, showing a higher rate of coronary heart disease deaths, non-fatal myocardial infarction, cerebral vascular disease, ischemic stroke, and other vascular deaths markedly increase in persons with diabetes. The only one that is not is hemorrhagic stroke, but the size of the box in whiskers notes that the number of persons with hemorrhagic stroke is smaller, most strokes and unclassified strokes, higher rates in persons with diabetes. Heart failure, powerful risk factor. Most of our patients with diabetes, if they live long enough, get cardiovascular disease. In fact, that is the #1 cause of death. It is not from high blood sugar. It's from the ravages of hyperglycemia on the vascular space. Heart failure can be found both HFrEF and HFpEF, systolic and diastolic heart failure, even in the absence of other risk factors. Here's a large population observational data from England, over 1 million, almost 2 million persons in the red, starting in the 40s, clearly related to aging. Persons with diabetes have more heart failure. Let's go into the medications. Metformin is the basic medication for most persons with type 2 diabetes. Insulin is being used in persons with type 2 diabetes, especially towards the end point of their life, and the glitazones are also used. I'm going to highlight the 3 at the bottom because these are the newer medications and their impact on cardiovascular disease. The TZDs, such as rosiglitazone, actually have not been shown to protect against cardiovascular disease and may be deleterious and increase heart failure. Sulfonylureas, which are the usual oral medicines, they're cheap. They're widely used, especially in racial and ethnic minorities and persons with low socioeconomic status, have equivocal safety. I'm not even sure they'd be approved by the FDA today if they had to go through the same rigors as the newer medications. Insulin is absolutely necessary for persons with severe diabetes and hyperglycemia, but the outcomes in terms of decreasing cardiovascular death and specifically heart failure is equivocal at best. The DPP-4s, such as saxagliptin, may actually increase the risk of heart failure, and the FDA has a warning for saxagliptin and aligliptin. However, the SGLT2 inhibitors, and I said I was going to give you the names, empagliflozin and canagliflozin, have actually been associated for the first time to show a reduction in heart failure hospitalizations, and I'll show you data to support that study. GLP-1, this is a hormone that's released from the gastrointestinal tract, and it has profound effects. It's an endogenous hormone, and now it can be made to be given by injection. It decreases the appetite. One of the formulations is actually used and approved by the FDA for weight control. It decreases gastric emptying such that the person has a sense of fullness. It affects insulin secretion and insulin sensitivity, glucose production, and around 11 o'clock on the dial has clearly been shown in at least one of the largest studies to show an increase in cardiovascular protection. Here are some of the mechanisms by which the GLP-1 affect the heart. In the middle, you see the blood vessel. It actually makes the blood vessels more pliable. It decreases arterial stiffness. It decreases inflammation and plaque stability. And I will show you data that these particular agents, specifically one called liraglutide, may actually decrease heart attacks in patients who have underlying atherosclerosis. The DPP-4s, therefore, block the degradation of the GLP-1s. They are really neutral in their cardiovascular effect, but the GLP-1s themselves, which stands for glucagon-like peptide 1, based on a large trial with liraglutide, which is one of these agents, all of these agents end in tide, has been shown, going from left to right, to decrease overall cardiovascular events, and a composite of cardiovascular death, non-fatal MI stroke. You see the Kaplan-Meier survival curve separate. The p-value is less than 0.04. Superior reduction in high-risk patients with type 2 diabetes using liraglutide. Decrease in cardiovascular death and decrease from death from any cause. You cannot say that about insulin. Insulin is important, and patients who have very poorly controlled diabetes will continue to use insulin and need insulin. But in terms of cardiovascular outcomes, insulin does not have anything at all that mimics these positive outcomes seen with liraglutide. Semaglutide is another. It also has outcomes. This is a smaller trial, not as confirmatory, but suggests that it may be a class effect, although it's only with liraglutide thus far the FDA has approved this particular agent for the reduction in cardiovascular outcomes and death. The SGLT2 stands for sodium glucose cotransporter. Basically what it does is blocks the absorption of sugar in the kidney. The person then urinates out their excess sodium and glucose and water. So it's a diuretic. By lowering the glucose, it also lowers the sodium and does have an effect on blood pressure and has been shown to have an effect on heart failure. This is the kidney nephron. I put a box around the proximal segment. This is where the sodium glucose transporter works. It blocks the reabsorption of sugar and sodium in the proximal tubule, so more of it comes out into the urine. The landmark trial was with an agent called empagliflozin. So the SGLT2 inhibitors end in flozins. With empagliflozin at the top, you see it cut death overall, blood pressure lowering, and weight loss. If you're losing sugar in the urine, you're losing calories. Liraglutide also caused weight loss, but through a different mechanism based on decrease in appetite and gastric emptying. This is basically wasting calories in the urine. Here's the Kaplan-Meier survival curves. Again, you want to see them separate, and you want to see statistical significance. Death from overall cardiovascular causes, non-fatal MI and stroke, death from cardiovascular causes at the bottom, and in the upper right, your left, hospitalization from heart failure. Because you're urinating excess volume, you're losing sodium and water. These agents, which are approved for the treatment of diabetes, have been recently approved at the bottom on the box by the FDA for reducing the risk of cardiovascular death in adults with type 2 diabetes and cardiovascular disease. I am a clinician. I still do research and lecture and fly to Saratoga and do all kinds of crazy things like that. But yesterday I saw 11 patients, and on several of them I recommend SGLT2 inhibitors in patients who have cardiovascular disease and high risk for heart failure. If you look at the data then, when you add the empagliflozin to standard care, it lowers blood pressure, you lose weight. We're really not sure exactly what the mechanism is. I mentioned it has a diuretic effect. It also decreases albuminuria, uric acid, and visceral adiposity. It's not just empagliflozin. This is another one, canagliflozin. Again, it ends in flozin. The Kaplan-Meier survival curves separate for overall cardiovascular disease. In the upper left, hospitalization for heart failure. The box at the bottom, canagliflozin is FDA approved for reducing the risk of major adverse cardiovascular events, stroke, and cardiovascular death in persons with type 2 diabetes and cardiovascular disease. So at least 2 members of this class of agents, if you have a high risk or you have documented atherosclerosis, have been shown to reduce heart failure for hospitalization, and canagliflozin specifically has an indication for overall cardiovascular deaths, strokes, and cardiovascular events. We really don't know why these agents decrease heart failure. While I spoke to the decrease in blood pressure, natriuresis, weight loss, diuresis, there are some data that it may also be related to the fact that when you urinate out the excess glucose, you change the substrate for energy into the heart and have an increase in the utilization of ketones for metabolism and an increase in ATP, which gives improved cardiac function. This is not proven, it's hypothetical, but perhaps it's more than just losing weight, decreasing blood pressure, urinating out excess sodium. It may actually energize the heart itself. In terms of the effects of empagliflozin on cardiac energy production, there are 5 bullet points here. I'm not going to go through them all. I'll go to the bottom one. There is some suggestion that the empagliflozin actually increases circulating ketone levels and provides the heart with an additional source of energy to sustain contractile function. Again, this is theoretical and not proven. As a cardiologist, the American College of Cardiology is now working with the American Diabetes Association to see if we could have an increase in utilization of these medicines because of their outcome benefit. This was recently published. It's an expert consensus decision pathway on the use of these novel therapies in persons with diabetes and cardiovascular disease. This is the pathway algorithm. At the top in green, if a person has diabetes and already has atherosclerosis, of course, in the purple, you address the other parts of the guideline-directed medical therapy, including lifestyle, antiplatelets, blood pressure, glucose lowering. I'm certainly not making the point that that's not important. But in the other box in the purple, they now suggest In addition to doing those things, you add an SGLT2 inhibitor or a GLP-1 agonist for additional cardiovascular outcomes benefit. In the green, I put a box at the top with red around it. If the patient has end-stage renal disease, the SGLT2 inhibitors and the GLP-1 agonists are not approved and should not be started. However, you should consider using, in the middle, the SGLT2 inhibitor if they have chronic kidney disease with GFRs greater than 45, and they may actually decrease progression of end-stage renal disease. And on the left, the GLP-1, liraglutide, has most of the data. That's the one that I showed you first. Is also suggested titrating slowly to avoid nausea and adjusting the other anti-hyperglycemic agents as needed. This is a table that shows the summary of the two trials. I'm not going to go into great detail, but you can see the size of the trials was substantial. IMPA-REG using empagliflozin over 7,000 patients. A combination of two trials, Canvas, showed over 10,000 patients the benefit of these class of drugs. So this is not a nuance. It's not a small amount of data. It's large clinical outcomes trials showing not only safety, but benefit with these agents. I put the box around the outcomes, cardiovascular death, strongest in IMPA-REG. IMPA-REG had more patients with documented atherosclerosis, so their cardiovascular death benefit was greater. And at the bottom, all-cause mortality better with empagliflozin, again, a higher risk population. And the last column, heart failure hospitalization, both of the agents decrease heart failure hospitalization. I know we have someone from the hospital here. The use of these agents may actually decrease hospitalization. In Medicare population, that's the number one cause of admission to the hospital. It's the number one cause of readmission. And it's a cost burden because there's a penalty when patients come in with heart failure and then are readmitted within 30 days. I've already mentioned the SGLT2 inhibitors have different mechanisms which are not all clear. This is directly from the ACC-ADA pathway, the natriuresis, which is urinating salt, the blood pressure lowering, anywhere from 5 to 6, as much as 8 millimeters systolic blood pressure, the weight loss because you're losing calories, the blockage of the sodium hydrogen transporter, and perhaps giving more ketones to the heart for better energy production. The GLP-1 agonists, the ones that are injectable, such as liraglutide, decrease blood pressure. They also decrease weight loss, but not because they urinate out excess sugar like the SGLT2 inhibitors, but they actually decrease appetite, decrease gastric emptying, so the person has a sense of satiety and fullness and does not eat as much with the GLP-1 agonists. So what's going to happen in the future? I don't know. Maybe the Saints will be in the Super Bowl. No, it's not going to happen? Okay. This is a meta-analysis which was just recently published looking at the SGLT2 inhibitors in primary and secondary prevention, and they confirm, both using empagliflozin, canagliflozin, and a newer agent, that there appears to be consistent reduction in end-stage renal disease and renal death with these agents. Again, it favors treatment on the right side of the line of incidence 1.0, and suggests that the decrease in heart failure hospitalization, overall cardiovascular death, is consistent across the various SGLT2 inhibitors. Furthermore, it's been suggested that a wide range of other outcomes, including the composite of MI, stroke, and cardiovascular death, may be beneficial. At the bottom, however, you see patients with multiple risk factors. These are patients who don't have documented atherosclerotic cardiovascular disease. The box, the diamond, sits on 1.0, so they're not approved for patients who are just high risk. These are beneficial as presently documented in patients who have documented atherosclerotic disease. This is the ADA and the European Association for the Study of Diabetes, who also came out with a recent paper in the management of hyperglycemia. And they have a strong recommendation based on consensus that patients who have type 2 diabetes with established atherosclerotic cardiovascular disease, you should use either an SGLT2 inhibitor or a GLP-1 agonist for their proven cardiovascular benefit as part of glycemic management. And the final meta-analysis, again, these are all recent publications looking at contemporary data, second-line anti-diabetic medications, patients who are given GLP-1 agonists, SGLT2 inhibitors, and to some extent DPP-4 inhibitors, although the data are not as robust. High cardiovascular risk, you should consider routinely giving these after metformin rather than using sulfonylureas or insulin. So in general, I think what we can say is that these agents are going to be used in the future. Cardiologists may actually start prescribing them. This is a study, Tulane is one of the sites, it's an international study using empagliflozin, and we want to see if it actually reduces heart failure, both preserved and reduced heart failure. The acronym is called EMPEROR. They had to kind of torture the name there to get to EMPEROR. But the idea is to see if these agents, even in patients who have not had documented heart failure, if you give these patients, it will reduce both HFpEF and HFrEF. So in conclusion, the FDA has now approved to decrease cardiovascular risk liraglutide, reducing the risk of MI, stroke, and death, empagliflozin, reducing the risk of overall cardiovascular death, and canagliflozin, reducing the risk of major cardiovascular events, strokes, and cardiovascular death. Thank you.